though I don't know why you're so much against radiosurgery. See, when I would like to counter you a bit because I have had experience of gamma knife for last 28 years. And when you're talking about radiation-induced meningiomas, those were from radiotherapy, not from radiosurgery. I have never seen a patient coming back after radiosurgery with a new disease. The previous one may increase, and they are far and few. Most patients actually do quite well. So, not every surgeon can be as good as you. Not every surgeon can remove the disease completely in difficult locations. So when the tumor is remaining, and if we don't treat that, if it grows further, what to do then? Because once when you could not remove it the first time, what are you going to do the second time? So it is very
May
handy
I,
in those.
okay, may I say something or not?
Yeah, sure.
Okay, gamma knife is good, but not for meningioma. You are showing maybe we are looking for natural history. Radiation therapy is bad. The majority of the people that the tumor that you are seeing today that induce if radiation therapy, 99% of the meningioma is not suitable for radiosurgery, but is larger. If sometimes remain a small piece, the natural history, you never know. And sometimes grow, but doesn't change the life of the patient. I have some patient that you did, I did surgery, I couldn't remove totally, and wait and see, and sometimes grow, but doesn't change the life. Radiation, the majority of the tumor, say it again, in the world, meningioma are not treating radios. Now expand the radiosurgery. Radiosurgery was one dose, one shot, a small tumor, low doses. Now is radiosurgery 1, 2, 3, 4, 5, 6, 7. It's not radiosurgery. It's radiation therapy. It's the same treatment did yes. We will see very soon the complication that's coming. And this patient will live 20, 25 years. And not see, sometimes you can give, of course, grade 2 meningioma, you need radiation. If you don't take totally, if you clean totally, I think you wait. But if there is tumor in grade 2, I think you should give radiation. Grade 3, you need to give radiation. But grade 1, give time to them. Maybe we are treating the natural history of the disease. Everyone here, Professor Gold, the best of us, Professor Gold, the best neurosurgeon of us, I'm sure that he has hundreds of patients that came to him. He said, wait, the people 4, 5, 6 years, no change. The patient live well. If I have a gun, I don't need to shoot everybody. I need to shoot him really deserves. Sorry. It's my feeling. But it's good. Radiosurgery is very good for several pathologies. It must be a neurosurgical business, not a radiation oncology business. In my continent, 99% of the radiosurgery is made by radiation oncologists without any consultation, any talk with the neurosurgeons. Neurologist, ENT, everyone, but don't come to neurosurgeons. If we are losing the business, you cannot lose it. It's our business, radiosurgery. Sorry.
Bernard, your talk was cut short. I would just like to ask you one question. How do you decide when to do a craniopharyngioma endoscopically and when do you do a craniotomy? You have to unmute yourself. Bernard, unmute yourself.
Okay, it wasn't allowing me for a minute. So can you hear me now?
Yep.
I'm sorry my talk was cut short, but I think lateral extension, you need a craniotomy, purely intraventricular tumors. I just got referred one actually just now, should be craniotomy. But for many of the craniopharyngiomas that are trans or retroinfundibular or preinfundibular, midline, The transplanum approach is an excellent approach. And the issue is that you can get under and behind the chiasm safely. That to me is a major consideration. So understanding the chiasm anatomy and involvement of the vessels and the ventricle are the three things we need to think about as we select the best approach.
Dr. Goyal, a question to you. Like, how do you deal with those bad atypical meningiomas which keep on coming back? Do you advise any chemotherapy to them?
You're
For me?
asking me?
I was talking Dr. Goyal.
Yeah, yeah. What did you
He
say?
has been
What
quite
was the question?
silent for some time.
Tell me, what is the question, Sandeep? Again,
No,
repeat.
so there are certain atypical meningiomas which, despite radiation, they keep on coming back. And so how do you deal with such patients?
You know what? My thoughts are a little bit like Louis. You know what I do is my strategy is to operate on meningiomas. And if I have to leave some tumor behind, I leave that tumor behind and wait and watch and pray that it will not recur. And if it recurs symptomatically, then I will see if my knife is safe, and if my knife is sure, I will like to reoperate. Whenever I think that my safety is, the surgery is not safe, or there can be some issue, or if the surgery, if I'm not able to, then I will consider adjuvant treatment in the form of radiation. So my indication of radiation is, as long as my surgery can be safe, even if I have to repeat, I will repeat and I will again repeat. But when I think that I know the surgery may not be the safest option, I may like to go for it. This has been my strategy for a long time, and I think this may be a good strategy, Sandeep.
I think we are running short of time, so I will invite down Dr. Nivedita Manjunath. She is working in UK to take the interview of the legend. So
Sorry, can I make a comment?
I see
Sure.
Dr. Kalangu here.
Yes, I'm
Kazadi.
here.
Sandeep, you asked all the
Okay.
questions. We'll leave any for Kazadi.
Yeah,
Oh, sorry,
thank you very much.
I couldn't see
I'll
her
be
Kazadi.
very short.
Professor Nautovich,
Yeah.
now all the
Hi.
team is here.
Hi.
I create so much
Good.
controversy.
I'm going to. I won't take much time. Yeah. Thank you very much for all the presenters. Yeah. You were all fantastic, and we learned a lot, and particularly our young colleagues who are actually watching us, and I'm sure they're delighted. There is one thing I wanted just to comment with my friend Atul, Professor Goel. I'm glad about your comment about the meningiomas. If you can leave a small piece of meningiomas, you just leave it. Because even when you remove completely meningiomas, within 20 years or 25 years, you start to see patients who are coming, yet you removed completely the meningiomas. So it's good to leave a bit of meningioma, particularly when this meningioma is attached to a vein or a structure, which is very important. So you have to leave that. Now, I have a question to my friend Atul. Listen, when you, I want just to make it clear for our young colleagues. When you say the art of demolishing the tumor, okay, what do you intend by that? I'm sure it's not a matter of hammer and whatever. What do you do to demolish the tumor so that you can avoid to do a condylar drilling?
Demolish the tumor means the art of breaking the tumor, art of breaking a vascular tumor, art of breaking a soft tumor, art of breaking a firm tumor, art of breaking a calcified tumor, art of breaking an ossified tumor. Every tumor needs different kind of strategy, different kind of skills, different kind of dissection. But we cannot say I do only soft tumors or I do only firm tumors. So we have to learn the art of breaking the tumor. First, we break the tumor and then we dissect the tumor from adjoining structures. These arts, many of these tumors can be in critical areas. You damage one perforator, you make the person devastated. You damage one cranial nerve, you make the person very bad shape. So if you remove the tumor but damage the person, that is not a good operation. So you demolish the tumor without affecting the adjoining structure. That is our life, and that is our profession, and that is what we have to learn. And most
Okay.
important for me is to minimize the extent of coagulation. That is to remove the tumor without too much coagulation. That is my trick.
Okay. Thank you very much for your answer. I guess when you say art of demolishing is gutting the tumor, basically. You go and remove the inside of the tumor and then you shrink it progressively. Is that correct? Is that my understanding?
Not shrink, but keep on demolishing, keep on breaking, keep on removing. Not shrinking by coagulation. I don't like that, I told you. Not shrinking, but break.
Not about coagulating. You empty the inside of the tumor, whatever you
That's
use. It can be Cusa, or it can be, if you don't have the Cusa, you still have to empty the middle of the tumor so that you can go around easily. Okay. Yeah, thank you very much. I think that was my comment, and I agree also with our colleague Bendo that anatomy is very, very important. To go to the lab and do it is very, very important. You have to practice all the time. Like the soccer players, no matter how good they are, they still practice regularly. So we
Every
should do
day.
the same as a surgeon. Exactly. So congratulations again, and that's all I had to come to say. Thank you.
So, any more comments?
I think we must get on. We are very late.
Yeah. So, is Giovanni Raffa here? I can't see him.